Hello, everyone. I'm Patricia Koffman, co-founder and communications director of the CLL Society, and I would like to welcome you to today's webinar entitled, MRD, What Should It Mean to Me? We will provide you with critical information and answer your questions covering everything you need to know about MRD, which stands for Minimal or Measurable Residual Disease. Prior to beginning today's presentation, I would like to mention a few reminders. All attendees on this webinar are muted. We ask that you please direct all questions to the Q&A section displayed at the very bottom of the screen. Scroll down with your mouse and the Q&A box will appear. Feel free to enter questions throughout the webinar, and our speaker will answer questions that have been submitted during the course of the presentation in the latter part of the event. The questions will only be visible to the speakers and CLL Society staff. After the webinar, you will receive a short survey. Please complete the CLL Society survey and give us your feedback as we continue to build this educational resource and plan for future webinars. Your comments are very important to us. This webinar will be recorded and made available on our website. You will be able to find the recording under the support group education section at cllsociety.org about a week after the completion of the webinar. We'd like to thank Genentech, Bristol Myers Squibb, and Adaptive Biotechnologies for making this webinar possible through their grant support. At this time, I would like to introduce today's moderator, Dr. Brian Koffman, Executive Vice President and Chief Medical Officer of the CLL Society. Dr. Koffman.
Thank you, Patty. Thank you to all of you for joining us this morning or this afternoon, I guess, depending. And I even think we have some people where it might be the evening overseas joining us. We're really lucky today to have as our guest faculty, Dr. Anthony Mato. Dr. Mato has done a number of educational activities with us, including a series on COVID-19 and how it relates to CLL patients. Dr. Mato is the director of the CLL program at Memorial Sloan Kettering Cancer Center in New York City, New York. And his primary focus is bringing excellent care to the patients that he sees with chronic lymphocytic leukemia. He oversees a team of experts that are dedicated to the appropriate diagnosis and management of CLL, developing the best treatment plans tailored to each patient's unique circumstances. He's involved in all the current therapies and provides access to new treatments through clinical trials. There's always many active clinical trials, and Dr. Mato is well known for his collaborative efforts working with other physicians, not only across the US, but across the world in terms of pulling together resources. The mission at MSK under Dr. Mato is to provide people with CLL with state-of-the-art monitoring and treatment throughout their clinical research, any research that they're doing, any treatment that they're receiving. So we're really lucky to have Dr. Mato. Let's move on to some poll questions before we get to the important part of the conference here. So the first poll question you can see in front of you. I am confident in my understanding of what MRD testing measures. And these measure from strongly agree, agree, neutral, disagree, or strongly disagree. The next question is, I am confident in my understanding of how and why MRD testing is being used in some CLL clinical trials and management. And again, the same list. And then the third question is, I have had MRD testing at least once. Yes, no, or don't know, not sure. All right. So it looks like we have a little less than half of the people agree that they understand MRD. So that gives us some opportunities, Dr. Mato, to grow those numbers. And again, about half understand what it means, but again, an opportunity to grow. And it's also interesting that about 50-50 split on if they've had it once or they're not sure if they've ever had it. Only about a quarter are certain that they've had it. So I look forward to seeing how you respond to this and what we're going to learn about MRD.
Great. Thank you so much. So really amazing to see nearly 400 people turning out for this topic, which I think does emphasize how incredibly important it is to be discussing MRD in the context of managing patients with chronic lymphocytic leukemia. Special thanks to my colleague, John Pagel, and friend who provided some of the slides for this presentation. So I think regardless of whether we're talking about MRD or traditional response criteria, assessment of the burden of disease, and when we say disease, we're talking about CLL, is really fundamental to trying to understand overall how therapies are working. For anybody with CLL who's had a therapy and their oncologist has tried to assess for response, responses are assessed in different ways, and we'll talk about those a little bit in some of the later slides, but it includes physical examination and history and bone marrow and CAT scans and blood counts and assessment of symptoms. All of that comes together to determine what is the traditional response, complete remission or partial remission. Today, we're talking about something beyond the traditional response criteria, using technology to look for as few CLL cells as possible. And so while a traditional response might be complete remission, you don't see anything with the eye under the microscope, the CAT scans have normalized. Today, we're going to be talking about technology that lets us look at 10,000 cells to see whether or not CLL is present, or 100,000 or 1,000,000 cells. So deeper and deeper ways to look beyond traditional ways of assessing for response. And why is it so important to assess for response? Well, first and foremost, you get a new therapy for CLL. You want to know whether or not it's working. And how do we determine that? Well, we determine that by whether or not the CLL is going away. A second potential use of these types of technologies is to determine whether or not the remission is ongoing. And so you've gotten into a deep remission, maybe MRD undetectable. Well, is there evidence that the disease is coming back before we can determine clinically if that's the case? And the same is true with the third bullet point about early relapse. They sort of go together. And one thing that we can all agree on is that serial assessment over time is required to monitor disease burden, whether that's the old-fashioned come into the office and perform a CBC and a physical and a history, or some of the technologies that I'll talk about today, which can be checked sequentially over time to look for the very earliest evidence of disease recurrence. Well, this is that slide that I alluded to in terms of assessing for disease burden. And with nearly 400 people here, I'm sure there's at least one person or several hundred people who've had many of these technologies performed to assess for response. Bone marrow biopsy to look for both healthy and normal and abnormal cells, FISH analysis to look at the genetics of the CLL to determine whether or not there's any poor risk features, CBC and peripheral smear to look at whether the cells are normal or abnormal and the percent of lymphocytes, imaging, which can be CAT scans, PET scans, MRI to look for whether there's improvement in nodal disease or splenic disease or liver disease. And then flow cytometry, which is a method for looking at cells through a particular machine that is able to look at cell surface markers and identify a fingerprint of the CLL cell and how many of those abnormal cells are present, are all put together in order to determine the extent of the disease. And unlike other cancers, CLL is a disease where there's different compartments. And so we talk about response in the blood or the bone marrow or on the imaging or on physical examination. The CLL cells like to live in different places. Well, then what is MRD? MRD stands for minimal residual disease. And it's a very important, relatively new technology that allows us to look beyond the traditional measures of response that I mentioned earlier. And so you can see on this figure, the blue cells are meant to represent, the blue circles are meant to represent healthy cells. The pink or orange ones represent unhealthy cells or cancer cells. And at diagnosis, there's a mix of both. And when treatment is initiated, the goal is to have, by whatever technology we're referring to, no abnormal cells present. And so, for example, in this case, remission, if we were using technology that let us look at 100 cells or 10,000 or 1,000,000 cells, we would want to see no abnormal cells present. And then in terms of monitoring, we want to be able to look at those cells closely and determine if a few cells are present. Oftentimes, by using technology, we're able to find a few cells present months or years before the patient actually has clinical symptoms that would warrant an intervention again. So part of the conversation to have with the oncologist is how to interpret those data. Because if a patient is MRD negative and then becomes MRD positive, that doesn't necessarily mean that they need treatment. but it's a warning that the disease may be coming back sometime in the future. And then of course, clinical relapse is exactly where we were in the first place. The disease is present, you can feel it, you can see it, the patient has symptoms. I'll mention a few studies just to highlight some examples of why this type of technology is important. And notice that most of the trials that I'll talk about are related to chemotherapy or bone marrow transplant and aren't necessarily relevant to people receiving more current and modern therapies. The issue is that this type of technology has been present for a long time using flow cytometry, for example. And so some of the oldest data and some of the longest term follow-up we have are from chemotherapy using flow. And so this is just a few examples of clinical trials where we see these types of curves called Kaplan-Meier curves, where they look at different patient populations that are separated for survival. It's always better to be on the curve that's closest to the top. That means a higher proportion of patients are alive and well. And the theme from all of these trials, looking at therapies like FCR or bendamustine rituximab versus FCR or antibody-based therapy, is that the ones who got the deeper remission tend to stay in remission for a longer period of time. So the deeper you go, the longer it takes to come out of that remission to the point where you have clinical progression that's detectable on physical examination or based on the blood work. So the deeper, the better in the world of chemotherapy. This is another study that looked at more than 2,000 patients and who had MRD testing. And the take home was that the deeper the remission, the longer the patient stayed in remission, and even potentially the longer the patient survived. And I'm just highlighting here, again, we're talking about chemotherapy-based treatments. And so when we talk about some of the more modern therapies, this may not be as relevant, particularly the BTK inhibitors. And just to get you guys involved in the lingo associated with these studies, you'll see a lot of UMRD, that stands for undetectable minimal residual disease, or undetectable MRD, or some people will say MRD negative. These are all the same terms. And keep in mind that they're not all interchangeable, and depending on what technology we're talking about, the depth of remission can be different. Flow cytometry might be only able to detect 1 out of every 10,000 cells, and I'll mention next generation sequencing a little bit later on, where we may be able to look at 100,000 cells or even 1 million cells. A lot of the research that we're doing now is trying to determine how deep do you need to go in order to best understand a patient's prognosis. The other thing that I'll mention is that these data really add on top of the traditional response criteria. And this is an example of 2 groups of patients who had a complete remission associated with chemotherapy. So everybody was in complete remission. That means when you did a physical exam and you did the blood work, there was no detection of CLL. But then they separated patients by using technology to look for MRD detectable versus undetectable. And the undetectable patients, the larger group, had a better what we call progression-free survival compared to those who had detectable disease. I think this emphasizes how far beyond we can go, beyond the traditional response criteria when we're thinking about assessment for residual CLL cells. And certainly the human eye may look at 100 cells or 1,000 cells. Certainly when we're using a microscope, it's not possible to count 10,000 cells or 1 million cells. And so that's where this technology may fit in best. And this is along the same lines, same type of data where we're seeing that for patients who are having a complete remission, the MRD status, negative versus positive, or even a partial remission, negative versus positive, tends to help to differentiate patient populations that do better. And what's really interesting to me is that the old response criteria of complete or partial remission tend to go out the window when you start to bring on MRD, meaning that a patient who's MRD undetectable who has a partial remission and a patient who's MRD undetectable who have a complete remission often have the same prognosis or a very similar prognosis. And so MRD status may often trump the traditional IWCLL criteria in terms of assessing for prognosis. And not only is this something that's recommended by CLL specialists or by societies like the CLL Society, which are really more of the, on the cutting edge of therapies or levels of detection of disease, but these types of assessments of disease burden are now being recommended by the NCCN, the National Cancer Comprehensive Network, or the IWCLL. So the guidelines are more and more incorporating the use of MRD in terms of assessing for response assessment. And of course, everybody who's participating on this call knows that progress has not been slow and steady in CLL, but it's been exponential. And between 2000 and late 13, 14, and the present day, we can start to count multiple targeted agents that have been approved. We have BTK inhibitors like ibrutinib or acalabrutinib, venetoclax as a BCL2 inhibitor, PI3K inhibitors like idelalisib or duvelisib. So every year, I would actually say every 6 months lately, it seems that we have a new therapy available for CLL. And so as therapy is progressing, MRD testing is also evolving and its relevance is also evolving. And while I talked about chemotherapy and I mentioned transplant, and I'll talk about BCL2 inhibitors, there are some drugs that we use that are modern and active and help to improve patient survival that don't necessarily induce a deep remission either. So I want to highlight that for patients who are on BTK inhibitors like ibrutinib or acalabrutinib or PI3K inhibitors like idelalisib or duvelisib, these are often once or twice daily pills that are great at controlling the disease, and they kind of pause the disease in place, but they don't necessarily induce a deep remission. And for certain modern therapies like BTK inhibitors, inducing an MRD undetectable remission isn't necessarily the goal of the therapy. And yet those therapies can improve survival and help people live longer and make them feel better. So the one thing that I want you to do is not walk away from this talk thinking that A, MRD has to be tested for every patient, and B, that if you're on a therapy like a BTK inhibitor and you're not MRD undetectable, that that's somehow a bad thing. 95% of patients who are treated with ibrutinib or acalabrutinib will never become MRD undetectable, and yet they can go on to have very durable remissions. So just keep that in mind as we go through this talk. There are other newer agents like venetoclax, which is listed here, that's now FDA approved in the frontline and relapse refractory settings that can induce deep remissions. And I find that the use of MRD with the modern therapies may be more along the lines of helping us to decide when we might stop those therapies, or also to address questions of prognosis when when patients have completed a fixed duration schedule. So different therapies have different value, where MRD has a different value for patients. This is just another example of a cellular therapy here. This is bone marrow transplant, MRD undetectable at the end of therapy, or at 12 months post-transplant was associated with a better chance of being cured. Not a big surprise there. Not a lot of patients are having a bone marrow transplant. I can go on and on and on with some of this data. This is another data set for FCR treated patients. And here the take home is that there may be even more value to deeper remissions. And so before, when I was talking about traditional methods of MRD assessment, it was 1 in 10,000 cells. Here they're looking at 1 in 1 million cells. And those patients tend to even do better. And so there is some evidence to support that while the original guidelines for MRD said, look in 1 in 10,000 cells, if you can't find a cell out of 10,000, you're MRD undetectable, maybe going even deeper is better. So that's a question that'll be answered over time. Certainly we have the technology to address those questions. I want to highlight a couple of different studies. One is called the Mato trial, which is a relapse refractory trial of a combination of venetoclax, which most CLL patients have heard of, plus rituximab, versus bendamustine rituximab. So new therapy versus old chemotherapy. New therapy was better. Patients had better progression-free survival and even lived longer as a result of receiving the venetoclax-based therapy as compared to the chemo. This therapy was an advancement in that it was 24 months of targeted agent and then everybody stopped. And at the time everybody stopped therapy, we start to have a window into the depth of remission beyond the traditional response criteria using MRD. And here we're going to talk about a cutoff of using 1 in 10,000 cells, or 1 to 10 to the -4th, or some people will call that MRD4. There's all different terms for that. And the take-home message was that at the end of therapy, the patients who were still MRD positive, which was a very small number of patients, tend to do worse than the groups of patients who were MRD negative or MRD undetectable. And so MRD has prognostic value at the end of venetoclax-based therapy. One of the research questions that our group and others are trying to answer is there something more that should be done for patients who are MRD positive at the end of therapy, or is there nothing that should be done and they should be observed and potentially treated upon clinical progression? So it's an area of active research. No one knows what to do with those MRD results, except that it helps us to divine prognosis better. This is a similar slide looking at MRD status associated with prognosis for the same patient population. And this is something that's really cool. If you look on the x-axis, this is time. If you look on the y-axis, this is the percent achieving MRD negativity. And I would only focus on the gray bars, which is the venetoclax. We don't really care about the chemotherapy at this point. But look, by 18 months, 60% of patients are MRD undetectable. This is unprecedented with targeted therapies, and certainly in the relapse refractory setting. So the majority of patients, more than the majority of patients, are MRD undetectable at or near the end of therapy. And I'll highlight one other trial called the CLL14 trial, which is that same impressive drug, venetoclax, combined with obinutuzumab. And now here you're getting that for a 12-month fixed duration schedule as compared to a comparator, the old drug chlorambucil plus obinutuzumab. We don't care so much about the comparison except to say that the venetoclax-based therapy was better. It resulted in more remissions, deeper remissions, longer lasting remissions. And again, let's not focus on the old therapy, which is the purple line, with the new therapy, the pink line, the venetoclax. Look at the depth of remission that happened for patients. This is now talking about MRD fractions that are 0.0001%. And look how many months post the completion of therapy that patients are able to stay MRD undetectable. So a very powerful combination. It results in deep remissions. And those remissions for patients who get to that state at the end of ven-based therapy tend to do better in terms of progression-free survival. I'm not going to go into the specifics of these trials. It's not relevant for this talk, but this is just to highlight that there are several trials that are being conducted across the country that have MRD as a clinically relevant endpoint. And not only for prognosis, but to actually help to guide clinical decision-making. For any patients in the New York area or patients who are followed at Sloan Kettering, we have several trials within our clinical trial portfolio that are specifically focused at using MRD to help guide stopping therapy with all of the modern therapies that I discussed today. So there are several technologies available for assessing MRD, available in practice and also in clinical trials. We won't go into a lot of detail today, except to say that the two most common approaches are flow cytometry. So utilizing a technique, a machine that's able to look at the cell surface, the surface of cells. We flag them with antibodies that have different colors and then count the colors. And that allows us to know how many cells are present. Or next generation sequencing, much more along the lines of when you're buying something in the supermarket, it has a barcode, you scan that code, it identifies a unique product. This technology allows you to develop a barcode for your CLL and then follow that over time with blood or bone marrow samples. So this is just an example of what flow cytometry looks like. You literally get a tracing that shows different cells with different scatter, and you know where the CLL cells are supposed to be. Here, they're supposed to be in this circle based on how the cells are scattering based on color. And that tells you how many cells are present. And obviously the goal would be to have this gate, they call it, or this circle empty. And that means you'd be MRD undetectable. And then that's the next generation sequencing, which develops a barcode based on what we call the B cell receptor and sequencing of the B cell receptor. And then we know the fingerprint of the CLL and we can follow that over time. One major difference between these two technologies is that the flow probably at best can get to 1 in 10,000 or maybe 1 in 100,000 cells. And the next gen sequencing can get even deeper, potentially to 1 in 1,000,000 cells. So an even deeper remission. What are we looking for when we try to decide which assay to send? At our center, we have options to send one or both. We look for how specific the assay is to avoid false negatives and false positives. Can it be standardized? Again, the sensitivity, which I just mentioned, and also how that impacts the patient outcome. And so we want to have data to support clinical decision-making based on the depth of remission. So in conclusion, MRD, minimal residual disease, provides additional insight beyond the conventional criteria for response assessments. Patients who are MRD negative have improved long-term outcomes, but again, I want to highlight, if you don't get anything out of this, to say that for some therapies that are modern, like a BCL2 inhibitor, this has more importance than the BTK inhibitor. So if you're on ibrutinib and the doctor has never checked MRD status, don't be surprised. It's not really relevant to those types of therapies. Patients who achieve undetectable minimal residual disease at lower levels have improved outcomes versus those who do not. There are several technologies available, and right now we and many, many others across the world are trying to work out which technology is the best fit for our practices and how to use it. And in the context of patient care, there are several ways in which MRD can be useful to inform CLL management and also inform patient prognosis. And so I really wanted to leave as much time as possible to get to questions, because I think that that's probably the most valuable part of these types of sessions. I wanted to thank everybody for paying attention, for logging in. Just the sheer number of patients who are participating here speaks to the importance of this particular topic. And I'm really looking forward to your questions. I'll try to answer as best I can. If they're patient specific, I'll argue that they probably should be discussed either with me personally, if I'm your physician, or with your CLL specialist, because it's hard to get into individual cases. And with that being said, I will turn it over to Brian.
So let's pause here and do the poll questions. So 2 questions here. The first is about your confidence in understanding what MRD measures, and hopefully have a stronger sense of that, and how and why it's used in some CLL clinical trials and management and not in some others. So a really significant change, Dr. Mato.
Thanks, guys.
I mean, at the beginning we had 16% that strongly agreed and 32 that agreed, and now it's up to a 94 between those two. And the same, 92% compared to 15 and 37 before. So I think you improved people's confidence, their understanding. Well done. And I think this is so important. Anthony, thank you for a great presentation. This, I think, really was thorough, and I'm excited that there is such interest in MRD because it's such a specific topic and it's so cutting edge. So I think it speaks volumes about the kind of sophistication and education there is among CLL patients in their involvement in care, because it really is cutting edge. Let me ask you a couple questions just from the CLL Society's point of view, and a couple questions that I've received. The first is, we like the language of measurable residual disease versus minimal residual disease. And we like the fact that it's called undetectable versus MRD negative. Could you comment on that? Because there's some shifts in the language.
Yeah, I agree with you. I think the undetectable and measurable are better, because the negative versus positive implies that all the tests are the same. And so, not to get into too much minutia here, but I may test a patient with flow cytometry and with next-gen sequencing at the same exact moment. The flow cytometry may be negative, but the next-gen sequencing may be positive at the same time, because it speaks to the sensitivity of the test. And so really, detectable versus undetectable is a better, or measurable versus undetectable is a better terminology. And you always have to think about what is the test and what is the sensitivity of the test. Because, it's really not a positive negative situation when when technology has different levels of ability and sensitivity.
Let me ask you another kind of broad question. You're a research center. If people see you, if they see Dr. Pagel, they're going to get MRD testing where it's appropriate, but it's not happening in the community to the extent maybe we'd like to see. Do you have any thoughts on that, and how patients might be able to talk to their community hematologist about this testing?
Well, I think, one major issue is that, you providing education to patients, I think goes a long way in having that conversation with the hematologist. Another barrier is that many centers just don't have access to testing. And so even some large academic centers, they don't have MRD testing as part of their routine panel, because you could argue, well, there's never really been a recent clinical trial that's proven it would change management. It only is helpful in determining prognosis. So the more studies that are done, and I speak directly to anyone out there who's involved with clinical trials that influence decision-making based on MRD tests, the more available these tests will be, because oncologists want to have tests that are actionable. No one wants to tell a patient your prognosis is good or bad and then have nothing to do with it, nothing to do about the results. I think the third issue is that these tests are becoming less technically difficult to do. And so, like the next generation sequencing, clonoSEQ, is just one example of a test that you can draw the tube of blood, drop it in the mail, and the company runs the test and sends you back a report. So you don't have to have like a big flow cytometry lab or a pathologist on site interpreting those results. These are becoming, off the shelf tests. You have the kit, you fill the tube, you mail it, you're done. The same is with some commercial vendors for flow cytometry. So as the technology is exportable and you don't have to have a big center like Sloan Kettering or MD Anderson to run the test, it's more available to people regardless of where you're cared for.
So there's a bunch of specific questions on the test. Blood or bone marrow, does it make a difference?
Great question. This is a little bit of a gray zone because it depends on the technology, it depends on the therapy, and it depends on the timing of the test relative to the most recent therapy. So it's hard to answer that specifically, but with the newer therapies and with the newer methodologies for testing MRD, it does seem that the concordance between blood and bone marrow is about 90%. So most of the time for my patients, I am testing MRD in the blood, particularly like on a therapy of like venetoclax, because I don't think for the 10% discordance, especially since we're oftentimes not making a decision based on the result, it's worth it for a patient to have to suffer through a bone marrow biopsy. So concordance is getting better based on changes in technology, but it's a little bit of a loaded question because if I were giving chemoimmunotherapy like BR and I tested MRD 1 month after BR in the blood and bone marrow, I might get a very different result. And so you have to have a lot of knowledge about the topic in order to know when peripheral blood is the best way to go.
Patients with primarily nodal disease, SLL patients, is there a role for MRD with them?
Patients who have primarily nodal disease oftentimes do have detectable disease in the blood and certainly the marrow. It's just not at the point where they are, where they meet the definition for CLL. So short answer is I do think there is still a value there because the nodes and the bone marrow and blood often track together. There are more sophisticated technologies, which I didn't touch on today, which are not routinely available, which can look at the DNA taken from the blood that's naked DNA and not from a cell in the blood, cell-free DNA they call that, and that's likely a measure of the CLL in the lymph nodes. So you can do a blood sample to measure the CLL in the lymph nodes, and that's probably something that's coming in the future.
One of the confusing things is it's possible to have undetectable MRD and only be in a partial remission, and it's possible to be in a complete remission and not have undetectable MRD. Can you walk us through
Sure.
how that's possible and what that means?
So I think probably the best way to start is to think about how does one define a partial remission versus a complete remission. Complete remission's easier. The blood counts are normalized. There is no evidence on the CBC of circulating CLL. The lymph nodes are normalized and they're on scans less than 1.5 centimeters in size. And when you look at the bone marrow, you don't see any CLL. So this is essentially using the eye and using imaging or physical examination to say, I can't find any CLL. A patient who is in a partial remission, for example, might have all of those criteria, except they have a couple of lymph nodes that are still 2 centimeters in size. They may or may not have CLL there. It may be just a big lymph node that was scarred and didn't return to the normal size, or the same with a spleen. So it's a very inexact science because it's not really measuring the disease directly. It's measuring a lymph node or a liver or a spleen and trying to say, well, based on its size, there's CLL present or absent. And that's not very exact. So for example, I could have a patient whose all of their lymph nodes shrink down to less than 1.5 centimeters, but like one remains at 1.6 centimeter. That's technically a partial remission. Yet when I look in the blood, there's no evidence of CLL based on depth of remission, 1 in 10,000, 1 in 1 million, whatever we're talking about. So that's a partial remission whose MRD undetectable. A complete remission might be all of the lymph nodes are less than 1.5 centimeter, spleen is normal. When I look with my eyes at the blood counts or the marrow, I don't see any CLL, physically see it, which is not so exact. But when I look at 1 million cells, I find 11 CLL cells. That's a complete remission that's MRD positive or MRD detectable. So that's how I would help you to understand how those situations might occur.
Now, I understand that you and colleagues are starting to do trials that are looking at MRD as the endpoint of the trial rather than the old criteria of are you in a partial remission, a complete remission, measuring that. Can you explain a
Yeah.
little bit about that and what the rationale is?
I'll give you 3 examples. We are opening a trial that includes venetoclax and obinutuzumab as a frontline therapy that does have an MRD decision point. But more importantly, for that trial, we've completely eliminated the IWCL, the traditional response criteria, and all responses are measured by MRD status. So no more CAT scans, no more bone marrows. The response will be judged by MRD. That's one example. We have another trial called the VENETO-STOP trial, which is all of our patients who are on venetoclax-based therapy. If they get to a remission that's less than 1 in 100,000 cells or less than 10 in 1 million cells, that's the same measure, they're able to stop and be observed, and then they're retreated sometime in the future if the disease comes back. The third trial we have is called a TGMRD study, which is the situation where we have patients who remain MRD positive or detectable on a therapy like ibrutinib or venetoclax, and there we add drugs to it in order to treat them till they're MRD undetectable and then stop. And so we're starting to design trials at our center that try to encounter different situations. Persistent disease by MRD, we do something. Undetectable disease by MRD, we stop early. And then clinical trials where the entire regimen is designed around MRD in terms of determining the length of exposure of therapy. And so it's using science and technology to tailor make the regimen for patients based on disease biology and depth of remission. And I really do think that is the future.
So there was a number of questions and you covered this, but I want to make sure there's clarity because some people are asking about this, that with the BTK inhibitors, with ibrutinib and acalabrutinib, first, do we know why they don't get to MRD while a drug like venetoclax does? And can you just, again, comment on the role of MRD with the BTK inhibitor, maybe on its own or in combinations, and just why that seems like a different story than it is with chemoimmunotherapy or venetoclax? And I would also say with cellular therapies like CAR T, where with the CAR T patient, we know that if they get to undetectable MRD, they do better than if they don't.
Well, the why is a little bit harder, but the mechanism of action for these drugs is that they interrupt cell signaling such that the cells kind of slowly die off over time, but the cell kill is really slow. That doesn't mean that patients don't benefit from the therapy. In fact, they can have almost all of their disease go away, their counts normalize, they can stay on them for years and years. But the general feeling is that BTK inhibitors are continuous therapies. You stop them, disease will come back. And so I think of it as almost like you can imagine it like an antibiotic that's stunning a bacteria so it can't do any harm to you, but at the same time, it's still present to a certain measurable extent. That paradigm works perfectly well for thousands of patients. And, you know, when you look at the data for drugs like ibrutinib or acalabrutinib, you see when they're compared to even the most, to modern therapies like, triple combination chemotherapies, patients not only have deeper remissions and have more durable remissions, but they actually live longer. So the paradigm that you have to treat until there's no disease present doesn't always make sense. And you brought up stem cell transplantation, which is a therapy that's capable of inducing an undetectable remission. Well, that's great, but it also has a mortality of about 10%. So we don't always need to treat a disease to the point that it's undetectable if the toxicities are very high. Venetoclax is another story because it seems to be well tolerated, but is able to induce those types of deep remissions. So it's not an all or nothing situation. And I would argue that for the nuances of BTK inhibitors versus BCL2 inhibitors and whether MRD needs to fit into your story, it's really a great conversation between you and the specialist. But again, I'll say this one more time. I don't want anyone to walk away from this thinking that they're on ibrutinib and that they have measurable CLL by MRD and that there's some kind of a failure. That's the expectation. And you can do very well and you can actually live longer as a result of receiving that therapy.
And there was a lot of questions about that. So I'm glad we're spending a moment on this because people are writing saying, well, if I have detectable disease and I've been on ibrutinib and I'm doing great after a few years, why not add venetoclax and wipe out that disease? And my understanding is there's no survival data yet showing that one is better than the others. There's no head-to-head versus these. So how do you approach that? I'm sure you get asked that in the clinic when patients ask about these questions.
You're right. There's no head-to-head data. And in my mind, when I'm thinking about choosing these different approaches, I don't have any strong data to tell me that one will do better than the other. They're both different. And in a situation where we're not curing patients with this new modern therapies, I expect that most patients will receive ibrutinib or acalabrutinib and venetoclax or vice versa at some point in time. The question about, well, why not just add venetoclax on and wipe it out? It's a great question in the context of research, but I would argue that you may be better off just staying on your ibrutinib until it stops working and then switch to venetoclax in that situation and then treat to an undetectable remission. Keep in mind, every time we go from one drug to two or two to three or three to four, it's not for free in terms of side effects. And so, yeah, you may wipe out a disease that didn't need to be wiped out in the first place, but you may add side effects or put your risk up for infection. So there's a trade-off. And so the only way to answer that is to do a study. And what we really need to do is have the pharmaceutical companies and the cooperative groups get together to do those types of studies to help guide decision-making. And they're happening a little bit now, but they need to happen even more.
So this is one you may want to duck, but it's come up in a lot of different kind of ways. Insurance coverage, inside and outside of a clinical trial for MRD testing. What's your experience with that for your patients?
I'm definitely not an expert on this one. My own just personal experience, and this could be a lot of bias, is that I don't hear from a lot of patients telling me that insurance didn't cover it. That's not to say that means that it did cover it. But I know like the clonoSEQ test, I think was just FDA approved recently. And so that should really, or I don't know if FDA approved is not the right term because it's not a drug, but there's guidance from the FDA that that's acceptable now. And so the insurance coverage for that technology in particular should be more relatively universal for patients.
Can you talk a little bit about the timing? So let's say a patient is on a regime and knowing that if they're seeing you, this is not likely to be a chemoimmunotherapy-based regime.
Sure.
So they're on usually a venetoclax-based therapy. Where MRD is appropriate, testing is appropriate, or they're on they've had cellular therapies. When do you do the MRD testing? How do you make the judgment about that? And then the follow-up question is, you've got an MRD, they're negative or positive. When do you follow up on that? How do you follow these patients? How often are you doing these tests?
Great question, Brian. And there's no standard answer as to what should be done. For me personally, the bare minimum is that I like to check MRD status at the end of therapy. So like if they're getting ven/obin and they're for a year, I'd like to check at that 1 year time point because that's the point where I'm stopping them. So if I'm having second thoughts or might want to continue them for any reason that's totally off label and not part of the approval for the drug, I might do it. So I tend to check MRD when I have a decision to make based on my own clinical style. Once they're MRD undetectable, how often to check it, I think is something that we're all working out. Everybody has their own style. Some people may never check it again. That's the right answer. Some people may check it every 6 months. That's the right answer. Some people may check it every 3 or every year. It really depends on your practice. I think the biggest question to always ask your oncologist is when they're sending a test like MRD, what are they going to do with the results? So if you're MRD undetectable and the oncologist is sending the test, you probably want to ask them, if I'm negative, will you do something different? If I'm positive, will you do something different? And if the answer is I'm not going to change anything based on the result, then it's probably not a good time to send the test.
So here's one that I bet you hear from some of your community colleagues, and it's asked by a patient here. Is there an argument that outside of research it might not be necessary? Meaning if a patient needs treatment again, we will surely find out. Can't it be a source of unnecessary anxiety and cost? I suspect that some healthcare systems outside of the US may take this back.
Totally valid question and a totally valid argument. And if I had to, be put on a podium and debate somebody and I was forced to defend that argument, I could justifiably defend it. So it's an evolving technology where we're learning how to use it. With that being said, I do love being part of a practice and at a center where I'm able to have access to technologies that aren't perfectly well worked out as to how to use them. I try to be part of the future, part of what's coming next rather than only historically using things. But that argument that you just made is totally valid. And until we have clinical data and FDA approvals that tell us what to do based on a test result, you could argue you don't necessarily need to do that testing.
Okay, there's a couple questions about how MRD status correlates with the rest of your CLL. Do you have is there any link between MRD status and your immune status? Are you more or less immune compromised if you're undetectable MRD? Does it mean that you can stop IVIG? Does it, things like that? Give us a sense of how it determines other than what treatment is needed for your CLL.
Much harder question to answer. I would say that there may be a very loose correlation, but keep in mind that the immune system is not all about just B cells. And MRD is measuring B cells by different techniques, but certainly there's other components to immunity. There's T cells, there are NK cells, there's myeloid cells. And so I can't tell you that just because the B cells are suppressed that the rest of the immune system hasn't recovered. My general take in CLL is there is no one test that's a healthy measure of the immune system. It's not easy to put a number to it. So I would argue very loose correlation at best.
And you talked about the correlation between bone marrow and blood, peripheral blood being 90%. About 90%. Isn't this dependent somewhat on the treatment? Like we know, like certain treatments are better at clearing the peripheral blood and some are better. Yeah. And do you sometimes see different levels of MRD in one compartment than another?
Yeah, absolutely. When I'm saying 90%, I'm largely referring to patients who are getting venetoclax-based therapy. And most patients are having a measure that's about 6 months out from the completion of therapy. So at that point, you see about 90% correlation. It's not perfect, but the question is, in order to have a better assessment, like looking at the marrow, you have to have a bone marrow biopsy. So I tend to not do it because with that type of correlation, I feel like the risk versus benefit from doing the procedure is really outweighed by the risk.
All right. What's the standard test in a clinical trial these days? Is it still flow cytometry for MRD testing, or is it that no standard right now?
No standard. I think you can, if we search on clinicaltrials.gov, we could find many trials using one or both. I actually think the standard is to include both technologies and try to sort out the differences between sensitivity and also sort out the differences in terms of prognostic value the deeper you go. So if I had a study with unlimited funding, I would like to include both. I think if I could see which way the wind is blowing, that there's going to be more and more trials that are making decisions based on next-gen sequencing, based on the clonoSEQ.
There's a number of questions on this, and I know you've addressed it, but I'm going to hit you with it again. Are there any guidelines if MRD increases after discontinuing venetoclax?
No. If the MRD is increasing after venetoclax, the one piece of data that's not super available and well studied at this time point is how long will it be from MRD going from undetectable to detectable and from detectable to clinical progression. It may be a couple of years. So you may become MRD positive, 12 months after you finish venetoclax, and you may not get to the point where you need next therapy for another 2 years or longer. So it's hard to know the value of that, and certainly there's very little available in terms of clinical trial data to support doing anything about it. Now, in the world of transplant, which is definitely the minority of patients, it doesn't happen very often anymore, thankfully, because of all these great drugs. There is a little bit of data to say that if you're MRD positive, you'll do worse after transplant, and that you may be able to give additional doses of cells to patients, they call it DLI, donor lymphocyte infusions, to reverse the negative to the positive. And so there may be a role for treating MRD or molecular relapse, as some people call it, rather than wait until clinical progression where the transplant is likely to have failed at that point. But with the new drugs like venetoclax, the BTK inhibitors, even chemoimmunotherapy, I always tend to wait until a patient has clinical progression before I decide to do anything as my standard. With that being said, there's a few situations where I thought long and hard about adding in a therapy to address the MRD issue, but it's certainly not my standard of care, and it's not, there's no clinical trial data to support that decision.
And that would be true if the patient never achieves MRD. We're talking about a patient who achieved it. It would be the same decision if at the end of venetoclax, after a couple of years, they still have a small amount of detectable disease. It's an individual patient in front of you decision. Is that my understanding?
Yeah, and there are patients that progress after chemo or immunotherapy or targeted therapies. You know, technically their white blood cell count is elevated and they wait another year or two before they have symptoms that warrant intervention. I'm thinking of a particular patient of mine. I think I treated him with FCR back in like 2009. He relapsed in like 2015 or 16, and I finally retreated him in 2020. So his relapse happened 3-4 years before he actually needed a therapy. So it's a very individualized approach, and you can't just go based off of a number.
Right. The MRD testing that you're seeing in its relation to the white blood cell count, I think that's an important point that people have. What's the correlation? And if somebody has an elevated absolute lymphocyte count, is there any point in doing MRD? And how much correlation is there between the old school $10 CBC that the patient can get versus the more expensive MRD testing?
Well, let me put it to you this way. If you do a CBC and the white blood cell count is 22,000 and there's 85% lymphocytes, there's no value in doing MRD testing. I can tell you, you're MRD positive, you're detectable. The harder question is if your CBC is normal, you know, your white count is 6.5, the differential is completely normal. There are a few lymphocytes in circulation because having lymphocytes is actually part of being a normal person. We're supposed to have lymphocytes present. Their MRD can differentiate whether those cells are CLL cells or they're normal B or T cells in the circulation. So, you know, if the CLL is present, like I sometimes have patients who are on ibrutinib, their white count is still high, and then they ask me if they can have MRD testing. You know, then we just explain to them that we know the results of that test will be positive. MRD is only useful for looking when all of the normal known measurements can no longer detect CLL. So it's beyond the normal measurements.
And this would also be true for someone in watch and wait who had a slightly elevated absolute lymphocyte count, that odds are, even though they don't need treatment, or someone in remission with a higher white count not needing treatment, there's no point in doing the MRD testing on those people.
Because we know the results, they're positive. So there's no value in sending the test.
So let me ask, and so we're going to close up here, but are there if you could give us some final thoughts about what the present state is and what you see the future state will be for MRD testing for patients?
Sure. So present state is that MRD is not the standard of care, but we have evolving literature based on newer drugs that it's very useful to be MRD undetectable, particularly after receiving venetoclax-based combinations. So right now, it's very good at telling us prognosis. We can say, okay, you finish therapy, prognosis is better or not better. Future state is that oncologists will be able to take that information and make decisions based on the result. So for example, I give you 12 months of venetoclax, you're MRD detectable, I'm gonna give you another 12 months, or I'm gonna add a drug to it, or I'm going to do something, or enroll you in a CAR-T trial. I'm just kind of making up these examples, but that's what the future is. It'll be decision-making based on depth of remission, which I do believe is not future 10 years. I think it's future 1 to 2 years or sooner. And certainly in the context of our clinical trials at Sloan Kettering, it's what we're doing now.
And I would add, it's exactly what, and you know, my clinical situation, a lot of people listening do, is I had CAR-T therapy, and my team at the Fred Hutch and Dr. John Bird have used MRD testing, both in the bone marrow and the blood, on me to make decisions about whether I could stop taking the adjuvant kind of ibrutinib to tweak the T cells, and whether it was time for me to stop therapy and stuff like that. So it's being used on real patients in the real world right now, outside of clinical trials, to make treatment decisions. And I certainly, as a patient, felt much more comfortable stopping ibrutinib when I knew that I was undetectable MRD by clonoSEQ testing in the bone marrow. It made me say, okay, it's safe for me to stop this drug because I don't have any detectable CLL. I know that doesn't mean I'm cured. I know that it doesn't mean that it couldn't come back, but it certainly, there's not a lot of reason to stay on it. One last question, I got to get this C question in about cure. You and I have had some discussions about the role of MRD leading to cure, and can you talk about that and maybe explain to patients a little bit about the difference between a functional cure and a cure, and how a hematologist or oncologist thinks about these, which is a little bit different than a way a patient thinks about these things?
I think oftentimes patients will think that if they're MRD undetectable, that they could be cured. And I guess what I would say is that being MRD undetectable is a likely step on the road to being cured. But when you look at the clinical trials, there are patients who are MRD undetectable who relapse. They just tend to do so at a later date. And so, one of the goals in all of the therapies that we design is to eliminate all of the CLL from the body. And one way to do that would be to treat it with a targeted agent or combination until there's literally nothing left. Well, MRD only has a certain sensitivity, so we assume if you're undetectable, it's possible that there could be nothing left, but there's no way to assess for that. So it's a step on the road towards a strategy that includes the word cure, but it's not the end of the road, I would say. The other thing to keep in mind is that when you're thinking about curing CLL, it's not just simply like nuts and bolts. This is not where the only goal is to treat until every cell is gone. Part of it may be it's okay for some cells to be left as long as the immune system is restored to keep those cells in check. And you could argue that if you had a situation where you could reinvigorate the immune system to keep CLL at a low level for the rest of the life, then that would be the same as cure too. So I think that the word cure is overly simplistic, but MRD is certainly a vital piece in knowing that we have strategies that have potential for cure.
I have one tiny technical question that just came in a minute ago that I don't want to skip. Can you do next-gen sequencing if the patient didn't have it done, if there wasn't a sample done when there was a lot of disease around? Now they're in a complete remission and we think they're MRD. Can you do NGS on a patient where you didn't get an early sample?
Yeah, so the art of NGS is that, in order to know that the barcode is gone, you have to know what the barcode was to begin with. And so it is true, you need to have some kind of a sample that has some of the CLL cells present in order to then know that they're no longer present. So I do think part of the future is we may just get the barcode on everybody in the beginning and then just decide if we're going to use it later or not, but at least it's registered so we know what to do. Most people who are treated have some sample somewhere, either an old bone marrow that's sitting around, you could use those slides, or a lymph node biopsy that's sitting around in the pathology department, you could use those slides. Or many centers have tumor banks where there's a couple of vials of cells that are stored away somewhere in a vault of cells, and you could use those cells. Or DNA. At our center, we have a lot of DNA that's stored as a result of similar testing that we have internally, which we could use to get that barcode. So we're getting more and more creative on how to get the barcode after the fact, but the technical answer is if you have no way to assess what that sequence was before you started therapy, then you have no way to assess if it's gone.
All righty. Dr. Mato, this was so helpful, and we've gotten tremendous feedback from people already. We're going to have to do this again next year, and because everything will be different at that point. I wanted to thank you and the team from MSK for giving us your time, because we know how impacted you are, and we deeply appreciate it. We're very grateful to Genentech, Bristol Myers Squibb, and Adaptive for making this possible. If we didn't answer your questions, we'll try to get to them. Thank you for attending today. Please fill out the webinar survey. We need your feedback. It's incredibly important to us to know. And save the date, October 10th. You'll see Dr. Mato. You'll see a lot of the docs that you've seen here before. This is going to be an incredible event on October 10th that we'll be covering. thanks for attending. This was, I learned a lot, and I deeply appreciate it. Thank you.
Thanks, guys. Bye-bye. Thanks for having me.